I'm Dr. Craig Escude, the host of IDD Health Matters, a podcast where we talk about health, wellness, and health equity for people with intellectual and developmental disabilities. Hope you enjoy it. Welcome to this episode of IDD Health Matters. We're coming to you from the American Academy of Developmental Medicine and Dentistry Conference in Denver, Colorado. And I have a very special guest today, Dr. Stephen Perlman. Welcome, Steve.
Thanks, Greg. Thank you for having me here.
So you are foundational to the beginning of this whole organization. Tell us the story.
It's really an amazing history how AADMD got started. So I was approached by Eunice Kennedy Shriver, who is the founder and CEO of Special Olympics almost 30 years ago, to create a health program for the athletes of Special Olympics. Special Olympics has 5 million athletes in 170 countries. And it was an unbelievable task, but at the request of Eunice and Sergeant Shriver, I undertook to create a health program for Special Olympics. So I'm actually a pediatric dentist. My practice was always limited to dentistry for children, adolescents, and people with disabilities. And so I started a pilot in dentistry and called Special Smiles. And then we went into vision, and then we went into medicine, and then we went into hearing and other disciplines. We now have 8 disciplines, and it's the largest public health program in the world. Okay?
That's fantastic. That's amazing.
But how do we tie it into AADMD
Right.
is the story, right? So nobody knew about the health disparities that existed because people with intellectual disabilities are the largest minority population that is ignored by everybody. And public health people focus on Native Americans, African Americans, and Hispanics, and nobody was looking into health of people with intellectual disabilities. And it's interesting because when I first met Eunice and Sergeant Shriver, it was an amazing experience to me because Sergeant Shriver is an amazing American hero, Peace Corps, Job Corps, Office of Economic Opportunity, led the war on poverty with LBJ. And Eunice Shriver, who is the champion of health, quality of life issues for people with intellectual disabilities. The third person in the room was Dr. Robert Cook, who was the founder of developmental pediatrics in the country. At that time, he was the head of pediatrics at Hopkins, and then somebody from the Kennedy Foundation. And when Mrs. Shriver met me, and why she met me was because I treated her sister, Rosemary Kennedy. Rosemary is my patient. And so here I am, 2 weeks after treating Rosemary and Mrs. Shriver, and we're talking, and she asked me to talk to her about why is dental health the most unmet healthcare need for people with intellectual disabilities? And I said, Mrs. Shriver, I don't want to talk about dental care, I want to talk about health care. And she said, what are you talking about? So this is the world's champion for people with intellectual disabilities.
At that time,
she said to me, I'm the champion. I devoted my whole life to this. Number one, I thought for people with the intellectual disabilities to succeed in this world, education was first. So I fought for IEPs and the highest education that somebody can achieve. Number two, what are they going to do when they grow up? Because everybody has to feel useful. So I fought for job opportunity. And third, with the closure of the institutions, where are they going to live? And I'm concerned about safe housing. I never thought about their health.
All of those things are extremely important components. But
social determinants.
But even now, I've experienced something similar to that, where as states move to move people into more community settings, they are still thinking about all of those things, and they say, oh, well, they'll just go to the doctor in the community or the dentist in the community to get their health care or their dental care.
Right.
But they don't always recognize that maybe people aren't trained to meet those healthcare needs.
Look at this. I mean, I'm sitting, Bob Cook was the medical director of Special Olympics, Dr. Cook, and he couldn't even convince her. And he was the parent of 2 children with Cru-de-Chat syndrome. And he said that they were institutionalized because he said they would not survive in the community. And and she said, what do you, and she challenged me on that, but Dr. Cook supported me. And that was the start of the career that I went on for the next 30 years, in addition to my private practice and teaching. Okay, so next step, right?
Right.
Okay, so we plug along for a couple of years, growing into the other disciplines. And then we realized that we really need to have a game changer. So only the Kennedys could have done this. Senator Ted Kennedy arranged for the first ever Senate hearing on health disparities for people with intellectual disabilities based on the work that we'd done in Special Olympics. I had to pinch myself that we were actually, so it was held at the Special Olympics World Winter Games in Anchorage, Alaska in 2001, okay?
That's really not that long ago when you think about it.
Yeah, well, fell into my body that's aging. But so here we are. First ever Senate hearing off-site, but it was still a Senate hearing. And everybody in the federal government had to come up and testify. At that time, Arnold Schwarzenegger was the chairman of fitness for the president, so he was up there. But, CDC, NIH, birth defects, the LEND programs, the USAIDs, every single agency had to be there. And it was led by Surgeon General David Satcher. And at that conference, I was able to get a one-on-one talk, like you and I, with Surgeon General Satcher. And I gave him some health and statistics, and he had no clue about anything. But he made the commitment to me to have the first ever Surgeon General's Conference on health disparities for people with intellectual disabilities before he left office. And so in December in 2001, 6 months later, we were in Washington, D.C. for a 2-day conference, and everybody that was anybody in ID at the country was there. And I was with Mrs. Shriver when he pinned the highest medal that a Surgeon General can give. And he said, if it wasn't for that conference and for you at Special Olympics, we would not be having this meeting today.
What a story.
Yeah. So what happened? The next week, Monday, Tuesday, Wednesday, I get calls from physicians all over the country. Steve, I met you. I'm a neurologist in New Jersey. I specialize in seizure disorders. I'm a gastroenterologist in Washington, D.C. I do all the scopes of everybody from the group homes in that area. I'm an anesthesiologist in Arkansas, and I specialize in craniofacial differences. All these people kept calling me. And so there was a meeting believe it or not, of the Southern Association of Institutional Dentists, which was a small, tiny little group. But it was in Chattanooga, where Rick Rader lives.
Yep.
And Phil May, who was one of the co-founders of AADMD, was lecturing. Phil's an endocrinologist working in an institution in New Jersey, but he was there. And so we all went to Rick Rader's house at night after dinner, and we said, we really need an organization of healthcare providers that are laser focused on healthcare for people with ID, because everybody's so siloed in medicine, right? 200 specialties in medicine. And so at Rick Rader's, we decided to form the American Academy of Developmental Medicine.
So that was kind of really the first meeting, was in his living room.
Yes.
Pretty much, right.
Exactly. Yeah. How crazy is that?
That is pretty neat.
And then we met. And so in the beginning, we were so small, nobody knew about us. So we met with the Developmental Disability Nurses Association, because a lot of the physicians knew that group. They had an executive director, and so it was easy for us. So we partnered with the DDNA for the first few years before we were able to branch off on our own.
And we've had a number of guests from DDNA on the podcast as well.
Still with us after all these years. The change, what happened was that as we got into policy and advocacy, the nursing agencies that support them and would pay for them to come, they were more focused on clinical care rather than that. Their bag wasn't that. Their agencies wanted to focus on clinical care, whereas we are policy, advocacy, and direct care.
Well, I remember, learning about the AADMD when I was practicing at a large intermediate care facility, and just didn't know anybody else who was doing what I was doing. Felt so alone, and I don't even remember exactly how I found out about AADMD. But I found out about it, and I remember going to the first meeting, and it was hugely impactful for me. It first helped me to realize that I wasn't the only one that was struggling with some of these things, but it was also really empowering to see that so many people were working together to help grow this field, grow an understanding of the need to improve healthcare, health and wellness, dental care for people with intellectual and developmental disabilities. And it's got to be pretty satisfying to see where it's come over the years from what you started back in Rick's living room.
Yeah, well, it's pretty emotional for me to see where it is today. I mean, really, because same thing with Special Olympics. I mean, now it's the largest public health program in the world. So I've really been blessed in my career that I've had a footprint in both the founding of AADMD, and it was totally founded Health and Special Olympics.
So, I want to go back to one of the things that you mentioned, how it was John F. Kennedy who really brought this to the forefront.
Exactly, because of his sister, Rosemary Kennedy.
And that goes back to the point of where we need a champion a lot of times, and a lot of times a champion in a position to make change for things to happen. And it was great that that opportunity presented itself at that time. But we see that on smaller levels too. At a medical school, there may be a champion. It might be a medical student in some cases, or it might be a faculty person who says we need to do something to get education about IDD healthcare into these programs, and somebody to keep on pushing that. And I'm sure you've seen that a number of times, or can you speak to that?
Oh yeah, well, one of the barriers to healthcare for people with intellectual disabilities is the culture of an institution. And like you said, if the dean of a medical or dean of a dental school is not at all interested or not focused on it, it's not going to happen. It's just not going to happen. And that's why, and it's sad, but that's, and because it's such an invisible population, but personal connection means a lot. Look at the data today. CDC latest report, 1 in 36 children on this autism spectrum disorder, right? So what person out there is not connected in some way? It's interesting. When I first with the health program when I started the health program in Special Olympics, and then Matt Holder discovered medically underserved population that, when he graduated,
to get the designation.
Wanted to get the designation, MEP.
And we're still working towards that.
I've been on this since 2004. Matt discovered it. In 2010, the AMA made that designated people with ID of medically underserved population. 2014, American Dental Association. But the bill that's before Congress now, called the Heads Up Act, is going nowhere.
Right.
And that's a struggle that we're having now. I was just at a meeting. It's interesting. Dentistry is the most unmet healthcare need for people with ID. Right. That's documented in the largest study the government ever did of 40,000 families of children with special healthcare needs. Dentistry was number one. Adult is much more. It's much worse.
Much more challenging.
Well, it's worse because the challenge is big, because Medicaid is a federal program, but it's up to the states as to whether they have an adult program. Medicaid under the EPSDD Act in dentistry is only funded for children up until the age of 18 or 21. And then it's optional for adults. And so many states still don't have an adult program or extractions and dentures. How crazy is that?
So that is certainly a barrier, the ability to pay for services. But what about dentists and training and feeling comfortable taking care of people with intellectual and developmental disabilities?
Okay, that's so for my 30 years, right? All I heard was lack of training in dental schools and lack of reimbursement, right? Okay, so we tried to. Lack of the reimbursement problem is an issue. We now have an organization called Medicaid, MISDA, Medicaid, Medicare, and CHIP, which is helping us. But it's never going to work with Medicaid, because Medicaid, the states don't have the money, and they're going to do their own thing. So we're looking at carving out in Medicare a program only for intellectual disabilities. Okay, That's one thing. That's relatively new, because we're trying to figure this thing out. Okay, as far as education, and this is really another interesting story. So when we realized, when I started this journey in Special Olympics, because basically I'm a private practice guy with an academic. I'm now a clinical professor of pediatric dentistry at both Boston University and University of Pennsylvania, but education. So there was nothing when I started this and looked to see, how am I going to fix this problem? Okay, broad, big picture.
Try to keep that microphone right there.
Okay. Big picture. Okay. So we looked at CODA, Council on Dental Accreditation. At that time, nothing in the curriculum that dental schools had to teach anything about health dentistry for people with intellectual disabilities. Nothing. So we wrote a letter to the commissioner, Mrs. Shriver, myself, and a doctor a public health doctor that I was working. And we said, hey, this has got to be an oversight. There's nothing in the curriculum, right? So we wrote a letter, and we petitioned them, and we lost. CODA would not put anything about education.
Did they give you a reason?
Yeah. After struggles to get the reason. No faculty to teach it, and the dental schools, no money on the patients because they were losing money on every patient. So those are the two biggest reasons. So we fought for a few years that it was unconscionable, and so they signed off to diagnosis and treatment planning only, which meant that a dental student and a hygiene student could graduate after 4 years without ever physically working on a patient with intellectual disabilities, okay? Rick Rader gets placed. First of all, 10 years ago, we were asked to speak before the President's Committee for People with Intellectual Disabilities in Washington about dental care. We brought it up. The chairperson at the time was not interested, but one person sitting in the room was interested and became our champion. He's now the current president of the President's Committee. President Biden just reappointed him. His name is Jim Brett, and he's from Massachusetts. Jim Brett goes on to become a member of the National Council on Disability, okay? And I don't know if he ever became president, but he was one of the vice presidents. Anyway, Jim calls me 3 or 4 years ago, and he said, Steve, I've got lawyers now, and we figured out how to make this change. And they did what I could never do. The lawyers went after the American Dental Association for violating the Americans with Disabilities Act. And so what they did was they took the code of ethics of the dental profession, right? Sorry. Code of ethics. So a dentist could not refuse to treat a patient because of age, gender, sexual orientation. That was it. The National Council on Disability made them insert the word disability in the code of ethics, which now meant that the dental schools had to treat competency, and that's the big game changer. So it's all AADMD and Special Olympics were the only ones responsible for that happening because of our persistence, our diligence, and our due diligence in giving the facts that was existed.
And that came about in 2019-ish?
3 years ago.
That's right. Yeah, that's what I recall.
That's been the game changer. And fighting, it hasn't been easy, fighting organized dentistry, okay? And it's been rough, but wow, what a game changer.
Absolutely.
So now every school is got to conform to training dentists. And of course the schools are going to differ, but take University of Pennsylvania Dental School. Every fourth-year dental student at the University of Pennsylvania Dental School has to spend 10% of their time in a personalized care clinic. Isn't that amazing?
That is. That's
10% of every fourth year's time.
Well, that's quite an accomplishment on your part and the part of AADMD and all of the people involved to get to that place. Probably more room for things to continue to move in that direction. Do you have any visions for the future where you'd like to see it go?
Yeah, well, we're working with, paying is important. I mean, there's so many obstacles to healthcare for people with intellectual disabilities. One of the biggest things is stigma. I've been told when I've been practicing almost 50 years, I just retired, but for almost 50 years, in the early years, I always heard, well, you do work on that population because you're not good enough to treat neurotypical people. You're not good enough to do implants and cosmetics. And I always heard that because it became, it's sad, but we've been so beaten down by the dental profession that it's so stigma, culture, accountability, regulations, problems with DSPs and the caregivers. These are all barriers. Because I'm convinced, like I said, it's always been education and reimbursement, right? But social role valorization, a lot of times, they're burdens on society.
Sure.
They're menaces. Why do we have to support them for the rest of their lives? These are the kind of things that we faced. And those are the additional barriers. But it's interesting that in states where reimbursements have drastically changed, or not drastically, but at least they're working on it, no increase in providers because they don't want to deal with Medicaid as a payer.
So it's still a challenge.
A huge challenge. Huge challenge.
And then you find one or two or three dentists who are willing to do that, and then they get overwhelmed with lots of patients.
Exactly.
Yeah.
Exactly.
It can easily get burned out as well.
Exactly. And the thing about this field is the better off you get. The other thing that's a big thing in the dental profession, and it makes my blood boil when I hear about it. It's like, well, I don't have access to the operating room. It's like, really? I had 1,200 patients when I retired. I had 1,200 children and adults in my practice specifically with disabilities. And my hospital utilization was less than 1% a year.
And that goes back to the training component of it. There are so many things that can be done. I mean, I've learned so much over the years of what can be done to provide healthcare, dental care in a normal setting, in a regular setting. And they're small things in some ways.
Exactly. In my talk, lecturing and teaching, and it's like 90% of people with intellectual disabilities can be mainstreamed through anybody's office without any modifications, okay? Then there are things like desensitization and behavior, all these things, and behavior guidance that you can do. But people are and legislators too, they're so focused on, we can't get used to the operating room. Well, so what? Treat the 95% of the people that you can treat, okay? And then, my model was always interdisciplinary care. So if I had to use the operating room and to get my work done, my first call was to the primary care physician and saying, number one, are they cleared for, because a lot of the comorbidities and secondary conditions that everybody had. But if I can't fix their teeth, well, nobody's looking in their ears. Nobody's doing a gynecology exam. Nobody's doing looking down their throat. Even I've had cases where in the operating room, an internist has come in with me to just. We had a case
do some
where
other exams.
A man was 23 years old. Nobody knew that he had an undescended testicle. The internist was never even able to get that done. So we had to call the ultrasound team because of the high incidence of cancers.
Right.
So every case that I did was like I said, first call to physician. What else do you want me to do? Almost every adult woman, can you please do a gynecology exam? Because I've had cases where people were in foster care and the physician wanted to make sure they were not sexually abused as well. Or in a case where we had
which we know there's a higher incidence of that in people with intellectual and developmental disabilities.
Totally. So I've had that model of complete interdisciplinary care. I mean, it's unconscionable to put somebody an adult for the teeth, and then what? You're going to put them to sleep to clean out their ears, and then do it again for a gynecology exam. So it's fragmented, and we still have to work on that.
So this has been fascinating. So glad we've been able to talk about.
Thank you. I didn't mean to go on.
No. This is great, and we're going to do this again and get some more. But one of the things I like to do at the end of each interview here is I ask guests to tell us 3 things in 3 minutes that you would like listeners to know about this field, to maybe work towards. 3 important components that, or things, words of wisdom. How about that? Words of wisdom to people that are out there listening that can help improve health and wellness for people with intellectual and developmental disabilities.
Wow. Okay. Because
3 things in 3 minutes.
I think I have ADHD now too, so it's really hard to tell. Well, number one, they're part of our community, and it's, there's been a lot of fighting going on. Should special care be a specialty? And I am so opposed to that because it gives for the medical and dental profession an excuse to let that person do it and not do it themselves. This healthcare for everybody is it's the communities. When we made the decision to take people out of institutions and put them in the community, it's up to our obligation to do it. So number one, and then for those people who are just starting out, You're going to have some things aren't going to work out sometimes.
That's for sure.
Yeah, like they say with autism, if you've seen one child with autism or an adult, you've seen one child with autism. Right. So the more this is totally true, the more you do, the better you get, okay? That's the third thing. And then I've always been taught that we as special people that take care of people with special healthcare needs, right? We that take care of people with special care needs. I've heard my whole career, in our field, it's like if you hear hoofbeats, it's not always a horse, right? Look for the zebra.
That's right.
Second thing, diagnostic overshadowing, which we really have to face much more in medicine than dentistry. But and then people say we have to learn to think out of our box, right? But right. I saw a slide in a lecture this weekend, and it said that we have to start thinking in their box too, which I thought, wow, I've never even thought about that. So
that's a good point to end on here is not just think outside of our box, but think in other people's boxes.
Exactly.
Well. Like that.
Thank you.
Well, Steve, thank you so much for taking the time to visit with me here at this conference, and I can't wait to see what happens at the rest of the conference. I think it's going to be a great conference.
Great. Thanks so much.
Appreciate you very much, and for everything that you've done.
Thank you. Thanks so much. Great to be here.